Welcome to Eye Contact. I'm Dr. Alistair Laidlaw. The choices available for the treatment of retinal detachments include scleral buckling, pneumatic retinopexy and vitrectomy. In the absence of any solid guidelines from randomized trials, how does the surgeon best decide on the right course of action? We're discussing this question with Dr. Borja Corcóstegui, Medical Director, Institute of Ocular Microsurgery, Barcelona in Spain. Borja is one of the most charismatic and best-known retinal surgeons around. It's great to have you here, Borja. Thank you.
Good morning. Thank you very much, Alistair.
So each of the standard approaches has people who like it and dislike it. What's your approach? How do you decide when you see a patient which way you're going to go?
Well, for me, retinal detachment is not a single disease. It's a variety of different situations. So we have on one side a small break with a small detachment, and we have on the other side a giant retinal break with a total retinal detachment. We have the PBR, and we have cases with no PVD and PVD. So we need to choose the surgical technique depending on the situation of the eye, on the lesions in the retina and in other parts of the eye, just to have a good outcome after surgery.
And do you have a broad approach where you can say that you'll do a buckle usually in one circumstance and a vitrectomy usually in another?
Yeah, I don't think one single operation can fix all the retinal detachments. That's, for me, one of the mistakes of the people now, which are comparing one technique against another one. I think that each pathology, each problem need to be fixed by different ways. So in some cases, buckle is the best treatment. And in other situations, vitrectomy is a very good treatment. And combination of buccal and vitrectomy in many circumstances, we can get very good results.
So perhaps if we explore that a bit more, is there a case when you see the patient, you'll say, I'm going to do a buckle on that?
Yeah, especially I select, and I think we need the best results for buckled in all the easy cases of retinal detachments. For instance, a case with 50 years old, a small retinal detachment superior with a small break. If you place a buckle, retina is going to be attached and finished. He's no problem anymore, he's no cataract, so patient is happy, everybody's happy and easy to fix. Also in the cases with young patients with no PVD, with small holes inferiorly, normally a woman with chronic detachments, and you can place a buckle, drain the fluid, and do laser or cryo, and fix the retina. That's very good results, never problems. And on other cases are the retinal dialysis.
Yes.
Also, we can fix with buckles very well.
So broadly, that would be the patients with a PVD, you might be thinking about a vitrectomy, and patients without a PVD, you'd be considering a buckle.
Yeah.
Okay, so in Barcelona, what proportion of the cases have a buckle?
Well, in Barcelona, we are using the buckle for cases with any complex situation.
Okay.
So, multiple breaks, giant retinal tears, superior and inferior breaks. So in situations which we are not completely sure we are going to fix in the first operation the retina. So in these cases, we place the buckle in the right position, which is very important, and then we use normally gas.
So this is combined vitrectomy and buckling. And what proportion of, so you've got vitrectomy alone with gas or oil, and we can explore that later. Then you've got vitrectomy and buckle, and then you've got buckle alone. So vitrectomy and buckle, in your experience, how many of those are you doing?
We are performing a lot. I don't know exactly the number, but we are having patients really with PBR after 2 operations and giant tears, and this kind of patients are referring to centers who are dedicated to retinal detachment surgery. So maybe we have more complex cases than other centers, and that's the reason because we are using more than this technique than other places, probably.
So how does the evidence that, the randomized trials, in medical retina, the randomized trials really drive forward opinion on how to do things, which drug to use when, that sort of thing. How do the randomized trials help in retinal detachment surgery?
Well, for me, the clinical trials in retinal detachments depend on many factors to have a complex interpretation of the results, because there are different surgeons, different education, they are using different instruments, so many factors, and you cannot compare one technique and another technique different for all the cases which arrive into your hospital. For me, I cannot do this kind of trials, because if I have a patient without PVD, I don't like to do vitrectomy alone, because I am sure I am going to have problems.
Yes.
And that's the reason, because these people in 75% or 85% of the cases, they have reattachment in the first operation. For me, that's not acceptable today. If it's a fresh retinal detachment, a new retinal detachment, you need to have the chance to reattach the retina in more than 95 or 95%. So if you have redetachment in 15% or more, that is not a good result. So.
Yeah, I have heard one of the criticisms of the SPR study, which is an absolutely fantastic trial and very difficult to put on, expensive and hard work and everything, was that it was actually a study of making surgeons, or could be considered a surgeon, making surgeons do operations that they weren't that comfortable with. So that people who liked vitrectomy were being forced into buckling, and people who like... have you found your buckling skills decline with time? Because in many centres, it's now, what, 92, 93, 94% of cases are done by vitrectomy. So I don't feel as sharp doing a buckle these days.
Well, I think the buckle is decreasing the use a lot, because probably the fellows in training is no practice on that anymore, and probably we are guilty of that because we are not teaching the buckle position, because it takes time to learn buckle placement correctly in the eye. So it's more difficult to place a buckle than to do a vitrectomy. It's much nicer to go inside of the eye, move the instruments inside and finish. You stay 1 hour. But buckle is much more difficult. People don't have training, and now nobody likes to do buckle, or only few people do buckles. I think that's the reason, because we need to promote the use in certain cases, specific cases, the buckles, because I am sure we have much better results.
So do you think there's a way around that, apart from saying you must buckle? Some people are advocating doing endo-illuminated buckling, aren't they? Putting light pipes in the eye, and then you sit at the microscope, which is where I feel more comfortable, and I grew up buckling, but I feel more comfortable at the microscope now. And endo-illumination, do you think that's a route forward?
Well, I am using also the microscope to do the buckles.
Yes.
But I am not using endo-illumination, because normally I have a lot of practice using the binocular scope, and I prefer to use laser delivery system to treat the breaks during the operation. I have a lot of training. I was working on that in the last 35 years, so I have very good training. I check the retina and I treat the breaks directly with the binocular.
Thank you, Borja, for joining us.